This presentation is for the College of Southern Nevada EMS Paramedic Program. Today we're going to talk about bundle branch and fascicular blocks in 12-lead interpretation. Before we begin, I'd like to go ahead and review the electrical anatomy of the heart. Electrically, we're going to go ahead and start up here in the right atrium. Right here, of course, you have your SA node. Then you're going to have your internodal pathways here that are coming down into the AV node. Your AV node will then turn into your His bundle. As it comes into the interventricular septum, it will then bifurcate into the right and left bundle branches. The left bundle branch is not a solid piece of tissue like the right bundle branch is that just propagates a signal all the way down into the ventricles. The left bundle branch bifurcates into an anterior and a posterior fascicle. The posterior fascicle kind of is like fingers as it comes off of the left bundle branch here to depolarize the posterior aspect of the left ventricle and the superior aspect as well. The anterior fascicle does run straight down a little bit further until it finally terminates into the Purkinje network. And of course the right bundle branch comes down and terminates into the Purkinje network as well. I would also like to briefly review R-wave progression, but more importantly than R-wave progression through the hexaxial and precordial leads, I want to talk about septal depolarization. When we talk about septal depolarization, what I'm talking about is the interventricular septum and how it actually depolarizes through the ventricles. So what will happen is you'll have your right bundle branch and your left bundle branch. Now your left bundle branch, as it comes off the His bundle, is a much larger piece of tissue because it has more tissue to depolarize. It has a larger ventricle to depolarize, more muscle. So the left bundle branch initially is a larger cable, as it were, that has more electricity and can propagate the signal faster. Just like any larger cable can send an electrical current further and faster than a smaller cable. Now, you're also going to have a small septal fascicle. Because of those two reasons, the left bundle branch is a larger cable than the right bundle branch, and the septal fascicle, what will happen is the left side of the interventricular septum will depolarize first, and then it will send a signal towards the right side of the interventricular septum. In leads 1 and AVL over here, what you're going to have is a small, cute, petite little Q wave. Now, this Q wave comes from the fact that the septum is depolarizing from left to right. Because it is depolarizing from left to right, it is depolarizing away from these lateral leads. And as we know, any signal that travels away from the positive electrode is going to have a negative deflection on the QRS complex. So what this means for us is that normal septal depolarization travels from left to right, giving us a small Q wave in the lateral leads. On the other hand, if you have an abnormal septal depolarization on the 12 lead, what that means is your septum is going to depolarize starting from the right side and traveling towards the left. Now, this usually occurs with a left bundle branch block. You block the left bundle branch up here, you're going to block the fascicle, the septal fascicle. The signal is going to travel normally down the right bundle branch and start heading up towards the Purkinje network, which means your septum is going to depolarize from the right side to the left side. Anytime you have this, you will end up with an absence of this cute petite little Q wave in the lateral leads because you're traveling towards the positive electrodes of the lateral leads. So abnormal septal depolarization here travels from the right to left. This will present with an absence of the Q wave in the lateral leads. And just to briefly review the normal R-wave progression through the precordial leads, in the past I have heard V1 through V6 is going to be little, little, medium, medium, and then big, big, being V1, V2, V3, V4, V5, and V6. This can be somewhat confusing because if you look at V1, you're going to have a huge QRS complex, as to where in V6 you're going to have kind of a smaller QRS complex. So people get confused about this little, little, medium, medium, big, big philosophy. It's a little bit better to think of it this way. V1 should have a negative QRS deflection. V2 should have a negative QRS deflection. V3 and V4 should be transitioning into kind of a positive deflection here. V4 should be primarily positive, and that would be considered a normal R-wave progression. V5 and, of course, V6 are supposed to be completely positive by the time you get over here to the lateral leads. That would be considered a normal R-wave progression. So let's go ahead and talk about the blocks that we're going to talk about today. We're going to talk about a right bundle, left bundle branch block, anterior versus posterior fascicular blocks. Sometimes these are also called a hemiblock, so you might hear that term. And I'm going to very briefly talk about something called a bifascicular block. You don't see those very often, but we'll talk about them briefly just so you have an understanding of what they are. When we talk about blocks, what I'm actually going to talk about is the interventricular conduction delay, because we're not actually blocking the ventricles themselves. There's just a conduction delay. The ventricle will eventually depolarize. It just might not depolarize immediately. The QRS sometimes will be prolonged. Now, when we talk about a prolongation of the QRS, we're talking about a QRS that's greater than 0.12 seconds, or 3 little boxes. Typically, the QRS will be prolonged in a left bundle branch block and a right bundle branch block. When we talk about fascicular blocks, there is a blocking going on in the left ventricle, one of either the anterior or the posterior fascicle. The difference, though, is that the QRS will not be prolonged in a fascicular block, and we'll get to that stuff here in a little bit. Basically, what happens, though, in a blocking of the left or the right bundle branch, the electricity has to travel around the myocardium. Now, rather than it using the superconductive pathways of the left and right bundle branch and the fascicles and the Purkinje network, now you have to use a cell-to-cell-to-cell transmission of the myocardial cells. If you're using the myocardial cells, you have to account for muscular contraction. So the muscle cells, whenever they do propagate the signal, it's a much slower process. It is very, very slow, which gives us the slow transmission around the myocardium, causing the prolongation of the QRS beyond 0.12 seconds. So let's now talk about the bundle branch blocks. The first bundle branch block we're going to talk about is the right bundle branch block. In the right bundle branch block, let's go ahead and draw in our conduction system here. We have our AV node here. Here's going to be our His bundle, and then we're going to have a right bundle branch, and then we're going to have our left bundle branch with the anterior and the posterior fascicles. So let's go ahead and look at the right bundle branch block. If the right bundle branch is blocked, what will happen is we're going to stop the bundle branch right here. Just pretend I'm just picking a spot here. What's going to happen is the septum will depolarize as normal. So you'll have normal septal depolarization, because the left bundle branch is going to come down and depolarize. The septum is going to depolarize normally from the left side to the right side. So because the septum is depolarizing normally, because the left bundle branch is not blocked, the left ventricle will depolarize normal. So you're going to have good septal depolarization traveling in this direction. You're going to have a nice fast transmission into the Purkinje network down here. But then what has to happen is that you're going to have this very slow transmission that goes around to the right ventricle. So the electricity will travel around the heart to the right ventricle. Now what that does is, if you look at the QRS complex, and primarily you're going to look at V1 and V2 to determine right or versus left bundle branch block. What's going to happen is, in V1, what you're going to have is something called a 2QRS phenomenon. What that means is you're going to have a P wave, and if you could separate everything out, you're going to have a QRS complex that will depolarize the left ventricle, and then another QRS complex that will depolarize the right ventricle. If you slap these two on top of each other, that's where you're going to get the RSR prime of your QRS complex in V1. So what happens here is, step 1, the normal septal depolarization occurs, and then the left ventricle depolarizes. This is steps 1 and 2 over here. Step 3, as you travel around the heart to the right ventricle, is this part right here. So you have your normal depolarization of the left ventricle and then the right ventricle, giving you a 2QRS phenomenon in V1 or V2. The morphology that you're going to see in a right bundle branch block, first of all, the QRS morphology is in V1 and V2. That's where you look. In V1 and V2 is seen as an RSR prime. That little apostrophe up there almost is what's considered a prime. A lot of times people will say what you want to look for is an M shape, or some people also refer to it as rabbit ears, that you will see in V1 or V2. What's going to happen, though, also not in just V1 or V2, but you're also going to have changes in your lateral leads. Now, in your lateral leads, what's going to happen is you're going to have something called a slurred S wave. Now, if you remember what an S wave is part of the QRS complex that follows the R wave but then travels below baseline. It has to travel below baseline for it to be classified as an S wave. Now, what that's going to look like is the S wave in the lateral leads is going to be your right ventricle depolarizing, because if you look at leads 1 here, and we'll say AVL is up here looking this way and looking this way, as the signal slowly transmits itself around to the right ventricle, it's slowly traveling away from 1 and AVL. That's going to give you, if you look over here, that's going to give you this slurred out S wave. And these are some different morphologies that you're going to see if you have a right bundle branch block. Please remember, though, the first place we need to look is V1. Then we look for our supporting criteria, including the lateral leads. So in V1, we have our left ventricle depolarizing, then our right ventricle depolarizing, causing this RSR prime. And in the lateral leads, we have our left ventricle depolarizing, which is this part here. And then when we get to here, the slurring out of the S wave is actually the right ventricle depolarization. If you were to measure this starting here and ending here, this would be greater than 0.12 seconds. These are some causes of somebody that would have a right bundle branch block: an acute anterior septal wall MI, an acute PE or any kind of infarction, acute onset of congestive heart failure, acute onset of myocarditis or pericarditis, hypertensive heart disease, and some congenital heart defects can cause an appearance of a right bundle branch block. Let's go ahead and look at a 12 lead here, and let's go ahead and interpret this like we normally would with the 6-step process. Our general impression, for me, when I first look at this, it actually looks good. Calibration, if you remember, is way over here. There's your calibration marker. It is 1 big box wide, 2 big boxes tall, so that's standard. Calibration. Now we're going to do our rhythm interpretation first. If I look here across, it looks all very regular. It looks like I have P waves. They're married to the QRSs. Let me see what my rate is. If I start here, 300, 150, 175. So I'm going to say it's a sinus rhythm at 75 beats per minute. It's supposed to be a 7, not a 2. R wave progression. Well, let's look at my R wave progression. I'm starting positive, I'm going biphasic, then I'm going positive, 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 positive in the precordial leads. The concern here is that there is no R wave progression. You can put poor or bad R wave progression, but you can just put poor for R wave progression. You can even put absent because there is no progression. My axis, I'm going to use the shortcut method. I'm going to look up here at lead 1, and I'm going to look here at lead AVF. 1 is up, AVF appears to be up, so since I have these two leads are pointed up, I'm going to say I'm going to have a normal axis. Now I can start talking about bundle branch blocks. If you want to look at bundle branch blocks, the first place you have to look is V1 and V2. You don't look at the hexaxial leads to determine bundle branch blocks. You have to look at V1 and V2. So, do I have an RSR prime in V1? Yes, I do. I actually have it in V2 also, but all I need is one of them. So I have an RSR prime in V1. I have a QRS that is greater than 0.12 seconds. Now let's look at my supporting criteria in the lateral leads. Do I have a slurred out S wave here in the lateral leads? I sure do. I have one there. I have one there. And I also have them over here in V5 and V6. And I even have a slurred S wave in V4. This would confirm that I have a right bundle branch block. So how would we interpret this 12 lead up to this point? I have a sinus rhythm at 75 beats a minute with poor R wave progression and a right bundle branch block. There we go. That would be my interpretation of this 12 lead up to this point. Let's look at another one. General impression, first thing I see is that it looks wide. Calibration, I'm going to look for some calibration markers. They're over here on the side. 1 big box wide, 2 big boxes tall, so it's a standard calibration. My rhythm interpretation first is going to be, it looks like I have a regular rhythm all the way across. It looks like the P waves are there married to the QRS complexes. The only problem I see with the rhythm is that it looks like that the QRSs are wide. So I'm going to say sinus rhythm at, what is my rate? I'm going to start here. Count using the countdown method, 300, 150, 175, closer to 100, so I'm going to say a sinus rhythm at, we'll say 90 beats per minute. R wave progression. Well, in V1 I'm supposed to be negative and I'm not, so I have a positive, 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 and V3, V4 is positive, 5 is positive, V6. So basically it's absent. I have no R wave progression. My axis, I'm going to look at lead 1 and lead AVF. Lead 1 appears to be either biphasic or up. I'd have to actually do the counting to see exactly if it's biphasic or up. But F is pointed down, so since 1 is up and F is down, using the right together, left apart, I'm going to say that this is a left axis deviation. For bundle branch and fascicular blocks, well, if you're looking for a bundle branch block, the first place you're going to look is V1 or V2. This right here is an RSR prime. You do have a small downslope, but then you have this little shelf right here on this V1. That is considered an R. That shelf goes up to an R prime. So that's actually an R prime, not an RSR prime. So since I have an RR prime in V1, and it's wide, it's greater than 0.12 seconds. Let's look at my supporting criteria. Do I have what I need in my lateral leads? So do I have a slurred S wave over here in 1? Yes, I do. How about here in AVL? Yes, I do. And here in V4, V5, and V6, I also have that really nice slurred out S wave. I usually just look in V5 or V6, but it looks like V4 is also picking it up as well. So I have all my supporting criteria to have a right bundle branch block. How do we interpret this 12 lead up to this point? So we'll look at our 12 lead interpretation now. It's a sinus rhythm at 90 beats a minute with poor or absent R wave progression, a left axis deviation with a right bundle branch block. Now let's go ahead and look at the left bundle branch and see how the left bundle branch looks whenever it gets blocked. Let's go ahead and look at up here. What do we have? Our AV node. We have our His bundle that comes down. We have a right bundle branch. Now we have a left bundle branch, and that's what we're going to concentrate on, is this left bundle branch up here. So the left bundle branch, what will happen is if the left bundle branch is blocked, the septum will depolarize abnormally, which means from right to left. So since the left bundle branch is blocked up here, the signal is going to travel down the right side, and it's going to depolarize the interventricular septum from right to left, from the right side to the left side. Now that's important because it's going to eliminate that cute petite little Q wave that we talked about before. So the signal will continue to propagate down the right bundle branch and into the Purkinje network on the right side. So you'll have your right ventricle will depolarize normal. And then the signal will have to very slowly make its way around to the left ventricle. So impulse, travel around, supposed to be a D, not a T, to the left ventricle. Now, like I said before, since you're traveling from myocardial cell to myocardial cell, you have to account for muscular contraction, which is going to significantly slow down the speed of the impulse. This also will give you a 2QRS phenomenon. The difference, though, is that it's not as easily seen in the left bundle branch as it is in the right bundle branch. But you can see a 2QRS phenomenon if you look closely enough for a left bundle branch block. The morphology that you're going to have for a left bundle branch block for the QRS complex, of course, anytime that you're looking for a bundle branch block, the first place that you're going to look is going to be V1 or V2. So we're going to look in V1 here. The first thing that you're going to look for in the QRS morphology is you're going to have a deep and wide, what they call maybe an RS pattern. What that means is here, any part of the QRS that travels up and then down, the first part that travels up after the PR segment or the P wave is considered an R wave, and then any wave that goes below baseline following an R wave is considered an S wave. So as you can see here, you're going to have a small up and then a huge wide S wave before you go into your T wave. This is what would happen in V1. Now, in the lateral leads, so I'm going to finish this deep, wide RS pattern in V1, and you might want to also look in V2. Now, in the lateral leads, what you're going to have is a wide and upright RS pattern or even an RSR prime pattern in the lateral leads. So as you look down here in V6, here's your P wave. You actually have an R. Now, ideally, this would not be considered an S wave because it doesn't travel below baseline, but sometimes it's called an S pattern. So you could also call this an RR pattern as well. But notice you have two bumps here. The first bump in this case is going to be the right ventricle depolarizing, and then as it slowly travels around to the left side, this is going to be the left ventricle depolarizing. The important thing here, and I could almost say that this is the critical criterion, is that you're going to have an absent small Q wave in the lateral leads. If you look here on V6, notice you have a PR segment that immediately goes into an R wave. There is no Q wave right here. The reason for that is that if you block the left bundle branch, the interventricular septum will depolarize from the right side to the left side. Depolarizing towards the lateral leads eliminates that little Q wave. So if you have a small Q wave in your lateral leads with this type of morphology, it's considered a nonspecific interventricular conduction delay. It is not considered a left bundle branch block. Sometimes you will also, depending on how bad the left bundle branch block is or the heart history, you may have a left axis deviation. This is just possible. This is not guaranteed. If you have a left bundle branch with a normal axis, then you just have a left bundle branch block with a normal axis. But it could be possible that you could have a left axis deviation. Let's go ahead and take a look at a 12 lead here. We have our general impression. To me, it looks wide. Calibration, I'm going to look for my calibration markers. Here they are over here, so I'm going to say that my calibration is standard. Rhythm interpretation first, I'm going to look down here. There's my P wave, QRS, and there's a kind of a flattening T wave in lead 2. So I'm going to say that this is a sinus rhythm at what rate? 300, 150, 100, so about 90. So sinus rhythm at 90 beats per minute. R wave progression through the precordial leads. Well, if you look at the R wave progression through the precordial leads, if you start up here in V1, you are actually negative and then negative, and this is negative, supposed to be transitioning, but you do have what appears to be almost a positive, if not a biphasic, up here in V4. V5 is positive and V6 is positive, so this could be considered a good R wave progression if you follow the rules. It kind of borderline, but it's still considered a good R wave progression. My axis, if you look up here in lead 1 and lead AVF, it's kind of hard to tell, but this one looks like it's more negative. This one definitely looks like it's positive, so right together, left apart, is going to tell me that this is a left axis deviation. Now we're going to look for our bundle branch and fascicular blocks. The first place you look for a bundle branch and fascicular block, V1 and V2. Do I have a wide QRS? Yes, I do. So my QRS is greater than 0.12 seconds. I need to measure it to get an actual number. But I have a wide RS pattern in V1. I also have a wide RS pattern in V2. Do I have a wide and upright in the lateral leads? I do in lead 1. I do in AVL. I definitely do in V5 and surely in V6. So I have a very wide and upright QRS pattern in the lateral leads. The last critical criterion is, do I have Q waves in the lateral leads? I do not have Q waves here. I do not have Q waves in AVL. And I do not have Q waves in V5 and V6. People in the past have said it looks like that there's a little negative deflection prior to the QRS complex in the lateral leads. And what they're talking about is that little thing right there. Now this is not a Q wave, this is actually a depressed PR segment. That is not a Q wave, that is a depressed PR segment, completely different, indicative of something else. So do we have the criteria for a left bundle branch block? Yes, we do. So we're going to have a left bundle branch block. So let's continue our 12-lead interpretation up to this point. Sinus rhythm at 90 beats a minute with a left axis deviation and a left bundle branch block. Here is another 12 lead. My general impression when I first look at it, it looks wide, and just by glancing at it, it looked fast as well. Calibration, unfortunately the thing kind of cut off my calibration marker, but there it is way over there. So my calibration is standard. My rhythm interpretation, if I follow my rhythm interpretation down here on lead 2, it looks like that it's a wide QRS, first of all, that's what it looks like. My P waves are there, they're married to the QRS complexes, it looks like that they're all regular, so I'm going to say a sinus rhythm at, what is our rate? Starting here, 300, 150, 100. So it's probably a little faster than 100, so we'll say a sinus tach at, we'll just say 105. Since I'm kind of rushing through this. R-wave progression. If we look at our R-wave progression, we start with V1, we're negative, V2 is negative, V3 is supposed to be transitioning, but it is negative. V4 looks to be a little bit negative, maybe biphasic. You'd have to count the positives and negatives and do the math. V5 is positive and V6 is positive. Generally speaking, you're transitioning from a negative to a positive. So we're going to go ahead and just for ease, we're going to say that this is a good R-wave progression. This could be borderline just because V4 is not positive like it should be, but we'll go ahead and call it good. Axis. What is our axis? Well, we can look up here in lead 1 and AVF, not AVL. 1 and AVF. 1 is pointed up. F is pointed down, so right together, left apart, gives us a left axis deviation. Since we have a wide QRS complex here, let's go ahead and look at V1 and V2. Do we have a wide, deep RS pattern in V1 and V2? Yes, we do. Let's look at our lateral leads. Do I have a wide upright pattern in 1 AVL, V5, and V6? I do. I meet all of that criteria for that. And now the critical criterion, do I have Q waves anywhere in my lateral leads indicating normal septal depolarization? And I do not. So I have met all criteria for a left bundle branch block. So left bundle branch block. So let's go ahead and finish interpreting my 12 lead here. I have a sinus tach at 105 beats a minute with a left axis deviation and left bundle branch block. Now I'm going to show you the shortcut method. I always show you how to determine this stuff using the normal long way, if you want to consider that, before I teach you the shortcut. Like I've said before, if all I teach are the shortcut methods, then when people get out into the healthcare field, into the working on the ambulance or working in the hospital, then they're going to shortcut what they learned, which was the shortcut method. So basically you're shortcutting your shortcuts. So if you learn it the long way, at least you'll understand the shortcut method. So let's look at the shortcut method. The turn signal method is what is used for bundle branch blocks. Now, this is just a shortcut method to get you headed in the right direction. Please remember, you still have to use supporting criteria. You have to. So the first thing that you're going to do is you're going to go ahead and start at the J point in V1. Remember, V1 and V2 is where you look to determine bundle branch blocks. So we're going to start here at the J point in V1, and we're going to start here at the J point in V1 also. So this is lead V1, this is lead V1. You start at the J point and you travel backwards. If you go down, then it's considered a left bundle branch block. If you start at the J point here and go backwards and go up, it is considered a right bundle branch block. Now the reason that this works is as a turn signal method is that if you look over here at your car, if you put the turn signal down, you're going to be turning left because your left blinker comes on. If you go up, then you're going to be turning right because your right signal turns on. Same thing here. Start at the J point and travel backwards. If you go down, you're going down, left, left. Start at the J point here and go backwards. If you go up, right, right. It's that simple. Like I said, though, you need to use the supporting criteria. If you're not sure which way to go with it, should I start off with a left or right bundle, this is what helps. Outside of this, though, you need to have supporting criteria to prove or to confirm that it is truly a right or a left bundle branch block.